We wrap up Disc 1 with a discussion Clyde Yancy had with Dr. Catherine Otto, the J. Ward Kennedy Hamilton Endowed Chair in Cardiology at the University of Washington in Seattle, on valvular heart disease guidelines.
Catherine, delighted to have you join us on ACCEL today to talk about these new guidelines. How are you?
Great. Thank you for inviting me.
Well, let's get right to it because I think there's much interest in the community about these guidelines, and I'd like to spend our time discussing some of the tips that you and the members of your writing committee thought were most important to emphasize. Let's begin with a descriptive approach, as in the stages of heart valve disease. What are those stages? How should we think about heart valve disease along the lines of the stages?
A major change in the new guidelines is instead of focusing simply on end-stage disease, we wanted to lay down the concept of valve disease stages going from the very earliest patient at risk to the end-stage disease. So using aortic stenosis as an example, stage A is the patient at risk of valve disease, for example, a patient with a bicuspid aortic valve or a patient with risk factors for aortic stenosis. And then stage B is what we tend to think of as mild to moderate valve disease, the patient with progressive valve disease who actually has established disease but is asymptomatic and does not have severe valve dysfunction. Stage C then is the patient who has developed severe disease by hemodynamic criteria but has not yet developed any symptoms, and then reserving stage D disease for what we think of as severe symptomatic valve disease. The goal of this was to focus people's attention on their patients earlier in the disease process so that we can learn to prevent disease and really optimize the timing of intervention.
And Catherine, I really congratulate you and the committee for coming up with these stages because there's an important concept here that symptomatic valvular heart disease is really stage D. And the emphasis, I think, is to consider interventions or halting the progression from one stage to the next long before patients become symptomatic. I think too many times in the community, we are waiting, anticipating, looking for that first symptom, but that's already stage D disease. So I have to believe that was one of the drivers.
Exactly. And I think we often have people who are waiting too long, even when they're past the early symptoms and into late symptoms. We really want to intervene right at that first symptom or even just a little bit before.
Well, let's continue because one of the new terms in our research vernacular these days is team science. But your committee also embraced team care, and you talked about the heart valve team, so much so that you gave it a class of recommendation 1, which literally means this should be done. Let us understand who's on that team and how that team can best improve or impact the outcomes of patients with valvular heart disease.
The heart valve team concept has come about as we've had a lot of advances in our understanding of the natural history of heart disease, but we also have a lot more interventions to offer our patients. So it's no longer just surgical intervention. We have interventional procedures as well. So I think historically, the cardiologist could see a patient and at the right time refer the patient to a surgeon, and a single cardiologist and a single surgeon could interact in the care of that patient, so the team was very small. But now we often need to have other people involved. We have a patient with valve disease, we're considering an intervention, we need to talk to the interventional cardiologist, we need to talk to the cardiac surgeon, we need the anesthesiologist to help with risk assessment, and then we have imaging specialists who help us define the anatomy and severity of disease, experts in valve disease, as well as other members of the team. So it's really the core members are what I said, the people involved in making complex decisions now that we have a complexity, a number of procedures we can offer these patients.
And it would seem as if, in addition to the number of procedures, we actually have the evidence, the data, that helps us understand the best fit for patient and procedure, because otherwise you almost have a free-for-all because everyone's thinking about their procedure, their approach. But since this can be data-driven, then I would think it's a more orderly discussion to decide based on risk, for example, which procedure would be best for which patient. And so that makes a lot of sense to us. Now, you also described that in the context of setting up these heart valve teams, it's not just the teams, but it's the centers. And so one has to focus on not just a sign on the wall, but a center with a real commitment to providing all the different disciplines needed to improve outcomes. So you described the heart valve centers of excellence, and again, you very strongly endorse this with a Class 2A recommendation, which means it really should be strongly considered. So give us a little bit more insight into this decision to really endorse the presence of heart valve centers.
Well, the Heart Valve Center of Excellence is defined as places that have high procedural volumes so that they are seeing a larger number of patients with valve disease and have low risk-adjusted mortality and morbidity rates for procedures. And this is really key because some of the recommendations are moving earlier in the disease process, for example, asymptomatic severe mitral regurgitation, even before we see left ventricular dysfunction. But we only make that recommendation if the patient can have a repair, not a replacement, at a center with a very low surgical risk and a high likelihood of a successful repair. So I think this is a place where the American College of Cardiology, American Heart Association are going to be involved in providing more specific definition. But the concept is that the Center of Excellence is a place that is doing a lot of procedures with low risks and has a quality improvement process and is also keeping data in a registry, so we are prospectively gathering information on these patients. Some of these procedures are complex and they really are not translatable to every medical center everywhere.
So I do like the way that you've suggested that this is a work in progress because it will take our ongoing attention to understand the threshold number of cases, the right quality metrics that should be achieved by these centers, how easily they can be replicated from one center to the next, and the importance of having the depth of commitment that's required to be successful here. Several times, Catherine, we've talked about the importance of understanding the risk profiles so that the right fit for the right patient can be achieved and the right resources can be available in these centers of excellence. That necessarily means that we have to have a way to calculate risk. And again, your committee did a brilliant job of emphasizing the STS score, the PROM calculator, and a new concept, assessing frailty. I think it's worth our time to just very quickly talk about this confluence of risk models that really helps us align the patients with the right procedures.
Yeah, and I think that's really critical because I think with the heart valve team, we're not really having each specialist say that their procedure is what should be done. I think we are working together cooperatively to decide which is the best procedure for this patient. And what we proposed was an integrative risk score, looking at the STS PROM score to start with to give an idea of surgical risk. And remember, it really does measure more surgical risk. But we also need to take into account procedure-specific impediments. For example, a patient with a chest wall deformity or previous radiation therapy may not be a good candidate for surgery, but that would not increase their risk for a transcatheter procedure. Conversely, somebody with poor vascular access might not be able to get a transcatheter procedure and would be lower risk for surgery. So procedure-specific impediments, as you said, frailty, and I think on frailty we're still working as to what's the best measure of frailty, but there are a number of objective indices out there, so we recommend looking at that factor because we know that frailty is associated with poor outcomes. So it's not simply that we want to include it, it's that we know that this is a predictor of outcome. And then the fourth part of this equation is other major organ system compromise that will not improve after the procedure. So if patients have no other organ systems, that's the low risk group, but if you start to have one or two or three or more organ systems, you move up in the risk score actually for both transcatheter and surgical procedures.
Let's get right to the real meat of this discussion. Aortic stenosis, a lot of new discovery, new technology, new approaches. Give us 2 or 3 summary statements about what's new in the guideline addressing aortic stenosis. I know that you've talked about a different way of establishing disease severity, new indications for transcutaneous approaches. So give us those 2 or 3 sentences, please.
So I think the first key is we're recommending intervention a bit earlier in that patients who have very severe disease, defined as a velocity over 5, or who have symptoms on exercise testing, which we consider equivalent to symptoms spontaneously reported by the patient, should undergo valve replacement because they really have severe symptomatic disease or soon to be symptomatic. I think the second major concept is that the indications for valve replacement are the same, whether it's surgical or transcatheter. The first decision is, does the patient need the valve replaced, or are they going to benefit from valve replacement? The second decision is, what type of valve replacement should they have? And that might be surgical, or it might be transcatheter, depending on the patient, with a subgroup of patients who may be so high risk that they're really not going to benefit from either procedure, in which case appropriate palliative care consultation and treatment is appropriate. Those are the two first that I think we can all understand. The third one is more complicated, is trying to get at those patients with low gradient aortic stenosis. And this is where I think referral to a heart valve team is essential, because these patients have calcified valves, they have a low gradient, there's a subset with left ventricular dysfunction that we recognize, but there's also a subset with small hypertrophied ventricles and a low stroke volume, and whom the diagnosis is difficult and is best done at a center that has dealt with this kind of patient before.
So, Catherine, I think you really helped our audience out terrifically by saying, you know what, the very first question is whether or not the aortic valve needs an intervention. After answering that question, either based on symptoms or the results of stress testing along with the assessments of the valve, then you make the decision about which approach, and you start incorporating risk, and then finally getting to this much more complicated issue of the nuance of aortic stenosis with the low gradient. In the time that remains, let's do the same thing for mitral valve disease. And I thought it was interesting that you adopted a nomenclature where MV capital R is mitral valve replacement, as we've always known it, but MV little r is mitral valve repair. So if you can give us just one or two statements about the renewed approach to mitral valve disease, that would be terrific.
So again, I think as with aortic stenosis, in the patient with severe symptomatic mitral regurgitation that is due to disease of the mitral leaflet, what we call primary mitral regurgitation, they need an intervention, and that's often going to be surgical, particularly if the valve can be repaired, with transcatheter techniques reserved for those who have a prohibitive surgical or high surgical risk. The patient, though, who's asymptomatic with severe mitral regurgitation, we now have enough data to know that patient is going to go on to develop adverse consequences. They're going to get atrial fibrillation, pulmonary hypertension, left ventricular dysfunction. So in some of those patients, if they have leaflet disease, severe regurgitation by hemodynamic criteria, even if their ventricle is normal, we can consider intervention before there are any adverse consequences. But that's where we only want to consider that intervention if the patient can have a repair at a center with a high likelihood of a successful repair, that they have appropriate anatomy for repair, and that the surgical risk in that patient is low. So I think that's where the guidelines are kind of pushing earlier in the disease course, but really in a specific patient subgroup. I think that's really the major difference in the mitral regurgitation. I just add, for mitral stenosis, because we have a balloon valvuloplasty procedure that's extremely effective, we changed the definition of severe mitral stenosis from a valve area of 1 to a valve area of 1.5, again, based on outcome data showing that patients do better with intervention.
Well, thank you for adding that nuance. One final question. From my point of view, the mitral valve disease I see most as a practitioner and investigator that looks at heart failure is functional MR. Any new insight on functional MR?
So I think this is a challenging problem. So functional or secondary mitral regurgitation is due to either a cardiomyopathy or ischemic disease, most common. So the first step in treatment is to treat the underlying disease. Now, defining severe symptomatic disease is challenging because, of course, they have symptoms from their underlying disease rather than from their mitral regurgitation. Similarly, they have left ventricular dysfunction from their underlying disease, not from their mitral regurgitation. So we continue to emphasize treating the underlying disease, considering medical therapy in some patients with cardiomyopathy, doing biventricular pacing, and really reserving any kind of intervention to patients with really intractable symptoms and persistent severe regurgitation, but really at a low level of evidence and not a very strong recommendation. So I think that continues to be a challenging area, and the problem is not really their valve, the problem is their myocardium.
Yeah, I would agree with you. Dr. Otto, it's been a real treat to have this opportunity to visit with you for just a few moments to understand what's new and different in the 2014 valvular heart disease guidelines. Obviously, there's a lot of great stuff there. Your committee is to be congratulated for doing great work and for helping practitioners have a better directive, a better handle, a better template in the treatment of patients with valvular heart disease. We really appreciate your participation in today's ACCEL program. Thank you very much.
Thank you for inviting me.
And that concludes Disc 1 of ACCEL. For details about studies discussed, refer to the written summary that's included as a PDF file on Disc 3. Disc 2 begins with a discussion on cardiac positron emission tomography enhances prognostic assessment of patients with suspected cardiac sarcoidosis.